Hi everyone, I'm Emma Eggleston, Dean of the WVU School of Medicine Eastern Division. Welcome to tonight's Mini Med School. The topic of our program this evening is early detection and treatment of breast cancer. So October is Breast Cancer Awareness Month, and we are fortunate tonight to have Dr. Nikki Soltani, one of our faculty members and oncologists here at our WVU Cancer Institute, to speak with us about early detection and modalities and treatment options. October is Breast Cancer Awareness Month, and here in the U.S., breast cancer is the #1 diagnosed cancer in women and the second cause of cancer death. Here in West Virginia, 1,300 women will be diagnosed with breast cancer in the next year, and approximately 300 will die from this disease. So early detection is absolutely critical. Dr. Soltani has been with us for nearly 4 years now, taking just wonderful care of our patients here in the Eastern Panhandle. She came to us from the National Institutes of Health, where she did her fellowship in hematology oncology after doing her internal medicine residency training at Geisinger Health Center. We are very fortunate to have Dr. Soltani caring for our patients here and speaking with us tonight. Thank you, Dr. Soltani.
Hi, my name is Dr. Soltani, one of the oncologists here at Berkeley Medical Center, one of the oncologic sites for West Virginia University. We have a lot of information to cover. October is Breast Cancer Awareness Month. As you can see by the schematic behind me, the female breast cancer incidence in West Virginia is one of the top cancer incidences in our state. Approximately 117.5 women in 100,000 will be diagnosed with breast cancer, and 22 approximate women in 100,000 will die from breast cancer. Breast cancer is essentially a family of diseases where the cells in the breast tissue grow without a check. And so this can form a mass of cells that either stay within your breast or travel elsewhere. You can also have other benign masses in your breast that are not breast cancer. What are the risk factors for getting breast cancer? 1, being female, 2, getting older, and 3, possibly genetic mutations that you can carry. There are some increased and decreased risk factors that you may have. These center around the time that you had your first menses, if you have a family history of breast cancer, and other things that you can see on this PowerPoint that we'll go through briefly. Another big risk factor is dense breasts. The reason this is a risk factor is because we cannot visualize the breast tissue as well. As you can see in this picture, a fatty breast you can essentially see through, which is shown on the right side of the screen, whereas a more dense breast on the left side that does not have masses in it is more difficult to find abnormalities. We try to reduce risk factors by assessing for genetic risk. This is typically found in patients who have either been diagnosed with breast cancer under the age of 45 in some cases, in other cases 65, or if they have any personal or family history of other cancers. These are typically gone through with either your family medicine doctor, internal medicine, OB-GYN, or an oncologist or genetic risk or a geneticist. Especially if you have a family history of multiple family members with breast cancer, regardless of age, or the presence of ovarian cancer, I would urge you to speak with someone regarding the possibilities of increased risk. We do multiple things to try to reduce your risk of getting breast cancer. One of them is preventative surgeries. This can include either a prophylactic mastectomy, which means that we remove your breast before it has anything that is malignant that appears within it, or we can give you risk reductive medications such as Tamoxifen or Raloxifene. We typically use an adjusted risk model to determine whether or not these would be indicated in your case, and genetic abnormalities that have been proven can also help with aiding that discussion. We try to do breast cancer screening in a hope to find malignant cells at an earlier stage. So we encourage people to get earlier breast cancer screenings. Typically when it's your first mammogram, you may have to be called back to further evaluate abnormalities that may be seen. But once those are found to be stable, it is good to continue to get routine mammograms in hopes of finding any changes. Other things that we try to encourage people to do is to know your breast. The days of having monthly breast exams have kind of gone down in recommendations, only because there's a lot of things that you can feel and find, and it has led to increased biopsies that have been benign in younger women. And so essentially what I tell people is to look at your breast every so often when you get out of the shower, to touch every so often, look to see how your nipples are pointed, if one has always been sticking out and now sticks in, or if you lift your arm and there's a dimple that's present, I would ask for you to go to see your primary physician to look into it further. Other things that are concerning are depicted in the picture behind me that we got from the Susan G. Komen website. This includes a new rash that's present. If you have new drainage from your nipple, regardless if you breastfed in the past, this is something that should be evaluated, especially if you're postmenopausal, or if you have a pain in your breast that is new and worsening, you should have a further evaluation. Typically what we will do if you come to us with these concerns is you'll get a clinical breast exam. A clinical breast exam is essentially someone who will go through and evaluate whether or not what they're feeling feels like a malignancy. They'll also probably check your lymph nodes under your arm to ensure there's nothing going on there. We also utilize mammograms. This includes 3D mammography in hopes of determining whether the abnormality that we feel looks like it has abnormal or increased risk factors on imaging. We use breast MRIs in women that have possibly denser breasts. This is not a standard with breast MRIs because it has higher sensitivities and it can find a lot of benign things, but in correlation with mammography, it's very helpful in assessing what we can do. When we have screening, as you can see in the picture behind me, we essentially try to find whether or not we can assess something or find a lesion that is smaller on presentation. So if you are someone who hasn't been having mammograms frequently and you palpate a breast mass, it's typically going to be around the size of a quarter. If you are someone who does have routine mammograms, the average size that you'll find is less than a dime. And if you haven't had a mammogram in a while, let's say 2 or 3 years, and they do a mammogram on you, or even if it's your first mammogram, the typical lesion is about dime sized. So what do we do once we find an abnormal mammogram? We do a diagnostic mammogram. This is typically something that's done with tomosynthesis, which is a type of highlight that we use to assess that area. We also use ultrasonography to assess for increased risk features that can be seen in that area. Or we can do a breast MRI, which we had also discussed on screening, that can help us further delineate whether or not it is close to the pectoral wall, or if it's involving lymph nodes, which is important when there are surgical interventions that are being planned. So the next thing that we'll try to do is to get a biopsy. This essentially gives us a snapshot of what we're dealing with. It tells us whether these cells are malignant or if they're benign, and we try to correlate that to the imaging. So if the imaging tells us there's high risk factors and the biopsy tells us that there was nothing found, we take that into consideration and see whether or not we need to sample again. The types of biopsies, very briefly, because this is a very busy slide, is a core needle biopsy, which we would prefer. It's a bigger hunk that we take out of your breast. There is a fine needle biopsy, which might be useful if it's hard to get to. And you can do an excisional biopsy, which we try to lean away from, because if there is the possibility of malignancy, we want to assess whether or not there are other factors at play, which will not be as useful if we take out the entire mass. So we try to guess, after we have a diagnosis of cancer, what your prognosis is. And we do this by relating the size of your tumor, the involvement of lymph nodes, and the possibilities of the cancer moving outside of your breast. And we gauge that on other individuals that have been graded the same way. So we look to see whether or not this is an invasive or non-invasive cancer. Ductal carcinoma in situ is a non-invasive stage 0 cancer, whereas invasion is from stage 1 to stage 4. We look at how large the tumor is. We look at how much the tumor has changed from the cells it originated from, which we call the tumor grade. 1 being very similar to the cells it originated from, and 3 being difficult to recognize the cells that they originated from. We also try to see whether or not these cells express receptors that allow us to treat it. One of them is assessing hormone receptors, the other is assessing HER2 receptors, and as the world of research continues, we're looking for more and more receptors to see what we can do to target these types of cancers. The hope with mammography and screening is that we find cancers earlier and avoid chemotherapy if possible, or try to treat someone before it's gone elsewhere, because the intent when you have a stage 3 or lower cancer is cure, whereas with stage 4 cancer, we have a more difficult time at achieving that feat. So the types of breast cancers are non-invasive ductal carcinoma in situ, or you have multiple different types of invasive cancer. Breast cancers are not all one and the same. They can originate from different areas of your breast. You have invasive ductal carcinomas, which come from the ducts. You can have cancers originating from the lobules, and you can have other areas of involvement that can signify how we can target what we're doing. Ductal carcinoma in situ is essentially when you have a collection of abnormal cells that haven't quite passed the barrier of invasion. So we know that they're cancerous cells, but they haven't quite invaded, which makes them lower risk, and the ability to treat that is just with a surgical excision. Chemotherapy in that case is not indicated. When we have invasive ductal carcinomas, you have a ductal which starts in the milk ducts. You can also have a lobular carcinoma, which is the second most common type. Am I good? Okay. Second most common type of breast cancer that originates in the lobules where milk is made in the breast. And you can have other things like inflammatory breast cancer. This is where a rash on your breast or a bug bite that hasn't gone away in months and is growing fast, or swelling of your breast can occur. And as you can see in this picture, there is swelling, there can be dimpling of the skin, there can be what looks like a rash that's spreading rapidly. Those are indications to see your primary care physician or gynecologist to further evaluate. Paget disease of the breast can occur along your skin, but it can also occur along your nipple. So if you have nipple changes, it's flaking, it's hurting, that is another reason why we would ask for you to come and see one of us. The next slides are a bit busy, but it kind of helps you understand how we as oncologists try to stage the disease that we have. This is an outline briefly of how we take a look at how large your at this point diagnosed breast cancer is. You can either evaluate it clinically, which is radiographically, or you can evaluate it pathologically, and we use both. It's helpful to have a prognostic indication prior to going to surgery. We also try to clinically evaluate your lymph nodes. Lymph nodes are present all throughout the body. The picture that you see is a lymph node that is drained from the breast, and this will be helpful in telling us whether or not the cancer cells have tried to leave the breast. When you look at pathologic staging, this is essentially after you have resected the breast mass. The surgeon will inject a dye, which we'll go into later in our talk, and we'll try to find the areas or lymph nodes that the cancer will drain to and remove those to see whether or not there are cancerous cells present. Finally, if there's any traveling of the cancer outside of the tissue of origin, in this case the breast, we call it metastatic breast cancer, and you get the M staging, which we outline below. And then we take this information and we kind of summarize it together. Depending on the size of the lesion or the involvement of lymph nodes, we give you a stage. Typically, stage 3 and below is a curative intent, and stage 4 is to hopefully prevent any kind of disease progression. But there are some studies that have been going on in hopes of conversion of early metastatic disease to a curative intent if we can. And I think this picture is much more helpful in describing what we tried to do with those very busy slides in the past. As you can see in the stage 0, there is a mass that's not invaded, so there's no red mark on that picture. In stage 1, which is the one to the right of that image, you have a stage 1 cancer, which is essentially just an abnormality in the breast. Stage 2 typically has lymph node involvement. Stage 3 has more lymph node involvement. And as you can see in the larger image on the left-hand side of the screen, metastatic disease has gone to other places. In this example, it shows the possibility of brain or lung or liver, which we hope to never occur. So what do? We try to essentially assess whether or not they have hormone receptors. This is part of the prognosis because these cancers all act differently. We look for HER2 receptors because we have different therapies that can be helpful in those situations. We look to see whether or not there's overexpression of HER2 to see if these targeted agents, which we'll go into in the future, will be helpful. And then you meet with a multidisciplinary team. You look and you meet a surgeon to see what surgical interventions are helpful. A medical oncologist will tell you whether or not chemotherapy or other risk reductive indications are necessary. A radiation oncologist is useful in trying to discuss the areas of local control. And you can use all of these modalities either singularly or in combination to try to achieve a good outcome. So, what does surgery do? They essentially try to remove the entire tumor. They have the bulk of responsibility in resection of the cancer itself. You know, the surgeons will take out the tumor in general. The medical oncologist is more useful for the possibilities of recurrence or in metastatic disease in the treatment and control. So you can have a lumpectomy where you take a very small amount of the tumor out, as well as the lymph nodes. You have a mastectomy where you take the entire breast out, and essentially lumpectomy plus radiation versus mastectomy have the same overall survival. So there isn't just one size fits all. You can have whichever would work the best for you. Breast reconstruction is very important to discuss with individuals. This isn't a vanity thing. This is a quality of life thing, because once you have your surgical resection, having another breast that isn't a constant reminder of what happened to you is important, and there are laws that protect you with that. So essentially, you can have discussions on breast conservation when you meet with your surgeon, and you can also discuss the possibilities of reconstruction at that time. So on the left of the screen behind me, you'll see how lymph nodes pretty much encompass your entire body, and these are like the highways within the body. They give you an isotope or a dye that into the area of the tumor that will drain into the first lymph node and tell us where that tumor area drains. When you have resection, they will also take that out. Once they take those sentinel lymph nodes, which are the first nodes that are drained, they will assess whether there's cancer cells present. Depending on whether or not at the time of surgery they see cancer cells, you may need to have more cells removed. Let's see. So this is just a very quick picture showing you a lumpectomy in the lymph nodes. And this is the differences between a mastectomy on the right-hand side, where it's just the breast tissue that's being removed, as opposed to a more radical mastectomy, which involves muscle and chest wall. So now we come to where medical oncology physicians like myself come into play. And we essentially try to evaluate whether or not we need to involve chemotherapy in your care before or after surgery. Neoadjuvant chemotherapy is prior, adjuvant chemotherapy is after. And you can either have these in pill form, injection form, and sometimes in very rare cases, there are times when you can directly put it into the organ of question, but these are not used as frequently. And I think in those situations, it's more of a last-ditch effort to try to control disease. So hormones are essentially made by your ovaries. Later in life, your body finds different ways of making these hormones, and we try to see whether or not these cancer cells express these receptors to see whether we could starve them. We have estrogen, progesterone, and currently being researched are androgen receptors, which might be helpful in that entire control using pill method. We also use things such as tamoxifen. Tamoxifen is usually used in pre- or postmenopausal women. This blocks the estrogen receptor on the cell, and it helps us control the growth or proliferation of cancer cells in the body. We also use aromatase inhibitors. This is typically in postmenopausal women or women that we've induced menopause. This is either use of something to suppress the ovaries or by surgical intervention. We use something called targeted therapy. There are various different kinds. I'll try to summarize them as quickly and in the least complicated way. But essentially, I think actually monoclonal antibodies we've heard a lot about because of its use with our current COVID-19 pandemic. But it's something that we have been using for some time when it comes to cancer and are familiar with. Targeted therapies are given as an infusion. They're antibodies that are made in a laboratory. It identifies the area of cancer cells and it tries to attach to them by either killing or preventing them from growing. And these are on the right hand of my slides where I talk about the different ones. This is the monoclonal antibodies. I'll list the names that may be familiar to people who are watching us, but these are trastuzumab, known as Herceptin. There's pertuzumab, which is Perjeta. You have adotrastuzumab, TDM1, famtrastuzumab, which has had a lot of really great outcomes from recent oncology conferences, which is on HER2. You have sacituzumab, which is really great for our triple negative breast cancers. This past 2 years has been really great for the triple negative and HER2 positive breast cancers because there's been a lot of new data coming out that's been very helpful. You also have tyrosine kinase inhibitors. These are another form of targeted therapy, block signals for the tumors to grow, and it can be used in conjunction with other cancer therapies to try to prevent growth. CDK4/6 inhibitors like palbociclib or abemaciclib and ribociclib are used in the hormone-positive breast cancers in the metastatic setting and have really changed breast cancer that has metastasized to other sites. We're not quick to jump to chemotherapy first, injection-wise. We are finding some really great control rates when it comes to these medications. mTOR inhibitors have also been used frequently. Everolimus is very commonly used. Typically, it's a next-line therapy in people who have failed earlier therapies that are known to work better. And the hope here is that it can prevent new vessel growth or the growth of the tumor itself, and by that means. We have Parp inhibitors. These have had really great outcomes in the triple negative and the BRCA1 or 2 populations. This again is pill form that's given with an oncologist. We can use it either for adjuvant therapy or maintenance therapy in other types of cancer. And so that's also helpful. And immunotherapy is the next up and coming thing when it comes to our cancers, triple negative breast cancer in particular. Earlier they had given us an approval for atezolizumab, which they recently the company took it off the market, but we do have pembrolizumab, which is known by the brand name Keytruda. The other ones that I've listed further on down, nivolumab, avelumab, those are immunotherapies that are used in other types of breast cancer, but they're looking into trying to see whether they can work in different ways. We have radiation oncologists that try to control local disease. These are not useful like our previous ones in the metastatic setting, unless there's an area of concern that needs to be focally controlled. So if you have stage 3 breast cancer and earlier and get a lumpectomy, you'll need radiation. Stage 3 cancers probably will also get radiation in addition to mastectomy if that's the route that's chosen. And you can see in this picture here how they try to avoid radiating the heart or the lungs and only radiating the areas of control or the areas of disease possibility. Finally, we try very hard to enroll individuals in clinical trials when we can, especially if there aren't great options for us in the standard lines of care, or if you have progressed on those standard therapies. Phase 1 trials are typically trials where there's new treatments and they're finding the drug dose that's the best. Phase 2 trials is when they have found the right dose and they're seeing how safe it is or how it works or how well it works. And then phase 3, they're comparing that perfected dose and an administration in comparison to standard of care. In oncology, you will not be given something versus placebo unless placebo is standard of care. We do not give substandard care to anyone with cancer. The hope is to just help it. So these are the pros and cons, which I kind of went through. I'll leave that up for a second. And so finally, we have some different ways of getting breast and cervical cancer screening. There is a great program via our public health system. And basically, if you want to get free or low cost mammograms, breast exams, or pap smears, and you fit these guidelines, I would urge you to try to contact the numbers that are present to see whether or not you would be eligible, because not having enough money shouldn't be a reason why you can't have your cancer caught sooner, and there are a lot of resources. We also have something called Bonnie's Bus, which is a 3D mammogram unit that goes across West Virginia. This is a really great program. You can always go to either our website or the Health Department's website to see where the stops will be. West Virginia University in the Eastern Panhandle has different imaging centers that you can go to. This includes Jefferson Medical Center, Berkeley, and Spring Mills. And in the month of October, as you can see, there is a discounted program. And finally, this is another great reminder of the screenings that we can do year-round. It doesn't have to be October for us. These are the resources that I use to gather a majority of the schematics and pictures in my talk. And if you want to see any of us over here, we're more than happy to meet you. That's all. Thank you so much for joining us, and have a great October.